invite Elizabeth Madam for her talk on true muscle transplantation in large angle strabismus. Madam does not need any introduction. Her name itself is enough. Welcome, Madam, for your talk on true muscle transplantation. Over to you, Madam.
Thank you, Dr. Meena, Dr. Arun. Good morning, everyone. This is a new procedure in strabismus, muscle transplantation in large angle deviations. See, muscle transplantation is a surgical procedure which involves suturing the resected autograft of the rectus muscle to the disinserted end of the opposite rectus muscle. In the diagram, you can see that a piece of the medial rectus is brought towards the lateral rectus and sutured. So that is the muscle transplantation. By doing this transplantation, we lengthen the muscle, and by further recessing this elongated muscle will produce further weakening. This surgery is used to correct large deviations. Indications are large deviations, especially sensory exotropias or esotropias with dense amblyopia, where patient is reluctant to operate the only seeing eye. It's not useful in paralytic squints or restrictive squints. See, this is a child with a very large ESO deviation with amblyopia in the left eye. Here, the goal of surgery will be to achieve a satisfactory motor alignment with no postoperative limitation of ocular movements, no induced lateral incompetence, no diplopia, and there should not be any enophthalmos, and we should have a good long-term result. That is our aim. And our options for large deviations right now is either supramaximal recess resect procedure. Supramaximal recess resect procedure will produce lateral incompetence and defective ocular movements. Then the other option is more than 3 muscle surgery. There, with the 3 or 4 muscle surgery, you can correct this large squint, but the patient will be usually reluctant to operate on the only seeing eye, the other eye being amblyopic. And hemi-hangback procedure is another procedure, and the muscle transplantation is the latest one. I have put in some review literature about supramaximal surgery. They say that supramaximal surgery will produce more lateral incompetence and enophthalmos. And hemi-hangback procedure have got the problem that the muscle may creep forwards and it may result in defective motility, and more than 3 or 4 muscle surgery is like this. You can achieve orthotropia, but you have to operate on the only seeing eye also. So here comes the importance of muscle transplantation, which improve the effective length. Chances of rejection of the muscle are none because it's an autograft, and since the position of the muscle is anterior to the equator, there is no limitation of extraocular movement. This is the child who underwent transplantation. You can see the video. So that's an esotropia. We are planning recession of the here, we are planning a resection of the lateral rectus and recession of the medial rectus. Now the lateral rectus muscle is hooked, and we are planning a 6 millimeter resection. So sutures are passed 6 millimeters behind the insertion, and the entire width of the muscle is woven by this suture. I use a 60 vicryl suture, and the sutures are locked in itself so that the entire muscle is kept in your suture. By applying this, after applying this suture, the suture ends are secured in a clamp, and then another suture is applied 1 millimeters behind the original suture, and in between these 2 sutures we are planning to cut the muscle. And after securing the suture ends, we go to the site of insertion. At the site of insertion also we put a pre-placed suture, so that we want a small segment of the muscle with 2 sutures on either side. After applying the suture, the muscle is cut. The segment of the muscle is cut like this, so that you get a 6 millimeter stump of the muscle. You can the muscle piece is cut at both ends, so that you get a 6 millimeter block of the muscle with sutures on either side. That way we retrieve a piece of the muscle, and then that muscle piece is kept securely in balanced salt solution. Then the resection of the muscle is completed by pulling the muscle anteriorly and fixing it close to the insertion. Then I close the conjunctiva with the glue. Nowadays we don't do any suturing of the conjunctiva, we do fibrin glue sorry, to close the conjunctiva. And now we have done a resection of the lateral rectus, and we have a piece of the lateral rectus that is transferred to the medial rectus. The medial rectus muscle is hooked and the piece of the lateral rectus is sutured at the insertion of the medial rectus first. I usually use only synthetic absorbable sutures, but there are surgeons who use non-absorbable sutures. Our sutures with this kind of sutures, 6-0 vicryl sutures, will dissolve only by 6 weeks, and by that time the muscle would have taken up. This you can see the muscle being grafted to the edge of the medial rectus muscle. This new stump of the muscle is an autograft. It will not have the contractile property, but it will act as a fibrous tissue later. Then now the lengthened muscle is recessed. You can see the medial rectus muscle is recessed by 7 millimeters. So we have a 7 millimeters recession with a 6 millimeter elongation that will give rise to about 13 millimeters of weakening. That will produce a huge medial rectus weakening, but since the medial rectus is still anterior to the equator, it will not produce any limitation of movement. You can see the postoperative picture. This is the first postoperative. Eye is orthotropic and movements are normal, and this is the late postoperative picture taken 2 months after. Compare it with the preoperative picture. The patient is orthotropic with only one eye surgery and movements are full. And coming to the review of literature, I have put in 2 reviews. One is by Amitava et al. Here he has said that this will not produce any limitation of movement. Another by Jitendra Jatani, and he also says that surgical results are stable. So this is a good procedure. To conclude, unilateral recess resect procedure with muscle transplant is superior to unilateral supramaximal surgery. This will produce better cosmesis, no lid fissure changes, no lateral concomitants. You can get primary position orthotropia. You can limit surgery to one eye, less traumatic and especially useful in large deviations with dense amblyopia. Thank you.
Thank you, madam, for this wonderful talk and very clear videos.